Our brain is a center of thought, feeling, memory, speech, vision, hearing, movement, and so much more. It sends messages through our spinal cord and nerves to transmit information to our entire body. But certain diseases of the brain and the spinal cord can block the normal flow of electricity and signaling. Now, there are safe, new, and effective ways neurosurgeons at Catholic Health Services can diagnose and treat problems in the central nervous system. That's on today's episode of CHS Presents Lifestyles at the Heart of Health. Hello, everyone, and thanks so much for joining us. I'm Jane Hansen. Catholic Health Services neuroscience team is dedicated to ensuring optimal patient and family care through advanced comprehensive neurological services. With me now is Dr. Magdi Shadi, Chief of Neurosurgery at St. Catherine of Siena Medical Center. Thank you for joining us. It's good to have you here.
Thank you for having me.
And I see you brought your friend, the brain, along.
Yes, it's my best friend.
Yes, and so the latest surgical things that you're doing, there's lots of advancements in medicine everywhere today. Mainly you're dealing with tumors, correct? Tumors of the brain and of the spine.
That's correct. The neurosurgery is going through a revolution, and especially because of the new technology. And we're able to adapt the new technology to use it to serve those patients with brain tumor. And in the Catholic Health Services Hospital, we have the state-of-the-art equipment now. Like in St. Catherine of Siena Medical Center, we just acquired the most up-to-date image-guided system that helps us to remove the tumor with great precision, accuracy, less complication, and better outcome.
It used to be that when somebody was told they had a brain tumor, at many times it was inoperable. Have you been able to change that kind of diagnosis now?
To certain cases, yes. Other cases, no. What this technology did is allow us to reach the tumor without going through the very sensitive areas of the brain. Mm-hmm. So in a way, we can reach the tumor and not to damage the sensitive part of the brain.
Can you show me, can we pick up the brain and show me what you mean by not through the sensitive areas and how that works?
This is a model. This is a model for the brain. This is the front, this is the back. Mm-hmm. We call this the frontal lobe, this is the occipital lobe, this is the parietal lobe, and this is the temporal lobe. Mm-hmm. So basically, if you look here, this is where the area that controls the movement. Mm-hmm. So if I go through this area during surgery, mm-hmm. the left side of the body will not work anymore. Correct.
Right.
So what did the image-guided system help us to do? Let's start first by saying, what's the image-guided system? Mm-hmm. This is literally like a GPS. Mm-hmm. You are driving your car. You start in this point, you're going to end up in this point, and this is the road. So what we do is we fix the head, and then we have an antenna carrying balls like that, and it's fixed to the table. And there is a camera that we see. If you look at the screen, this is how the system looks. Uh-huh. And then you see those two eyes, we call them. Uh-huh. This is infrared camera. Mm-hmm. So the camera receives the information we send from here through the camera to a very complex computer system. Use complex mathematical calculation to show us this. So what happened that when I have a pointer, after taking the information from the head to the computer, and I put this pointer on the brain, it showed me the picture we see on the screen. So now this would help me with a couple of things. Number one, make a very small incision. Let's assume the tumor on the screen is here. So in the old days, we used to make a big opening in the head because we are literally fishing for the tumor.
Uh-huh.
Nowadays, before even touching the skull, before opening the head, I put the pointer and I see this picture on the screen. So I design where I'm going to open, how big or small my opening will be, and which angle I will use to get to the tumor in a very precise way. So I mentioned earlier, this is the motor strip that control the movement on the opposite side. Before we had this technology, it's very easy to go through it with the surgery.
Right.
Because I have to make an opening in the brain to reach down deep to take the tumor out. Now, I know this is a motor strip. I see it on the image I obtained before the surgery, and I come from an angle to completely avoid this.
So it's much, much safer in terms of how you're going to affect the outcome, affect a person's ability to move and maybe even to think at times.
Absolutely. That's why the outcome now, using the Brain Lab image-guided system, is way better than before. I remember when I was a young resident, and even when I was an intern, working with the neurosurgeon, there was no CAT scan, there was no MRI, there was no image-guided surgery. And I remember where we use a needle to poke in the brain to feel the tumor so they can get it. And then if the opening is small, they have to make it bigger. Now, I make a very small opening this size, like a quarter, and take a brain tumor out, much less time, very precise, much less complication, much less bleeding, and the patient goes to the intensive care after the surgery. At the end of the day, we get a CAT scan, and this patient is literally ready to go home. Before, they used to be in the hospital a week, 10 days, sometimes 2 weeks. Now, it's very clear, cut, clean kind of surgery. And this is what the advancement has helped us to do.
Technology has really worked for you. How does somebody know? What are the symptoms that may indicate you have a brain tumor of some sort?
A lot of times, there is no symptoms. And this is with early brain tumor. But 50% or more of those patients will start with headache. And especially headache that could be progressive, or sometimes it could be in the morning, then in the, at night or in the afternoon. It depends on the location of the tumor. If the location is close to the motor strip, the part that controls the movement, the patient starts having weakness. If they have numbness, this means the tumor close to what we call the sensory area that controls the sensation. If it is close to the speech area, so they start having difficulty talking.
Sure.
So instead of saying the word, they say the wrong word. Or they know what they want to say, but it's not coming out properly. If the tumor is close to, say, the optic nerve, the nerve that goes to the eye.
There's eye issues. Got it. So there are some things that will give you clues about where a tumor might be or that a tumor actually exists. Well, this guided imagery surgery it looks like it's moved so far forward and it's been such a great advancement for you that I thank you very much for sharing it with us. Stick around. We're going to talk to you again at the end of the show, but right now we are going to take a quick break and we'll be right back after this. Welcome back to CHS Presents Lifestyles at the Heart of Health. Advanced image-guided navigation and treatments like brain mapping, available at Good Samaritan Hospital's Medical Center's Brain Lab, have greatly improved the outcome for patients with brain and spinal cord tumors. Joining me now is Dr. George Kakalides, who is a neurosurgeon at Good Samaritan Hospital Medical Center. Welcome. Good to have you here.
Well, thank you.
So what is brain mapping?
Yeah, so when we talk about brain mapping, we're talking about mapping out different functional areas of the brain. They're very often referred to as the eloquent areas of the brain. And in particular, we have a brain here. We're talking about mapping out areas responsible for motor function, sensation, vision, hearing, even speech as well. And the whole point of mapping out the brain is to, when you have a tumor, you want to remove and resect as much of the tumor as possible without causing excess harm. So you want to be able to map these areas out beforehand in order to resect the tumor safely.
Okay, so you're talking about, I know, like all these little colors in this brain represent different areas that have different functions. But when you map them out, is that meaning like you're literally taking somebody's brain and saying, here's where this part is, here's where this part is, etc.?
Yeah, so there are many different ways you can go about it. Some are done before surgery, some are actually done during the surgery, during what's called an awake craniotomy. When you're doing it before surgery, mapping out the brain, and I'm sure you're familiar with this, what's called functional MRI. It's when a patient goes into the MRI machine, they are told to move their hand or wiggle their toe, and then that area of the brain lights up, and that's where you can see where that area that's responsible for hand movement or leg movement. Additionally, there is another kind of MRI called DTI that maps deeper subcortical areas of the brain, the white matter tracts. And there's also the gold standard, which is called electrocortical stimulation, and that is actually stimulating the brain during the surgery and seeing if the function is inactivated or not. So you have a patient, you tell them to either count or name, and if they have a speech arrest during this time, that's when you know that is the area that is responsible for speech.
But so, did you just say people are awake during this brain surgery?
Yeah, so people get worried about that. Even patients are scared at times, but they are awake during the surgery. They often tolerate it very well. We have a team that is involved in doing that, including a neuroanesthesiologist who is often there and helps participate, puts the patient to sleep, wakes them up during that time. There is also a neurologist that sees the patient beforehand, goes through the certain tasks that they're going to be asked, and when the patient is awoken during that critical part, both the surgeon and the neurologist are there to talk to the patient and ask them certain questions.
Does this mean that everybody's brain is a little bit different about where we have certain functions? Isn't there like a general guidebook about a brain?
Yes, good question. We have a general idea of where each function is. So if we look at the brain here, this is the front of the brain, the back of the brain. The motor cortex is generally located here in the frontal lobe posteriorly. The area for speech is generally located here in the inferior frontal lobe, called Broca's area. Another area for speech, for understanding speech, is in the area called Wernicke's area. And in general, we have an idea of where that location is, but each individual differs, and that is why we use electrocortical stimulation, which is actually stimulating the brain to actually test out to the exact millimeter where that specific function is in each individual patient.
Wow, that's amazing. I know that at Good Samaritan, brain mapping has saved a lot of lives, including that of a local resident whose name is James Brush. He was able to walk his daughter down the aisle on her wedding day. Let's take a look.
Just 1 month before his youngest daughter's wedding, 62-year-old James Brush learned that he had a brain tumor. He needed immediate surgery.
I'd woken up and I had some slight slurring to my speech with a slight, I don't know how you say it, there was a discomfort on my left-hand side.
Mr. Brush was referred to Dr. Salvatore Zavarella, a neurosurgeon at Good Samaritan Hospital, who told him that surgery could not wait until after the wedding. But the surgery itself carried risks. Because the tumor was located near the motor strip, the part of the brain that controls movement, removing it could leave Mr. Brush with weakness or even paralysis on one side of his body.
Patients that harbor tumors in this area, and this could be in the frontal region, in the parietal region, or in the temporal region, we can safely remove these tumors by mapping out the motor strip or the motor cortex or the area of the brain that controls function. And so we can safely remove most tumors in their entirety and have the patients maintain normal function in terms of the movement on one side of their body. This is important for patients' outcome.
Good Samaritan is one of only a few hospitals on Long Island with the capabilities to perform this advanced surgical technique.
Not every hospital can perform this technique. Good Samaritan Hospital is one of the hospitals in the area where we have a team to be able to perform brain mapping. We need anesthesia to be able to provide a specific form of anesthesia. We need a neuromonitoring company to be able to specifically monitor the motor function on one side of the body. And so Good Samaritan is one hospital that allows us to have a team approach to be able to take care of tumors that are located in this area.
This state-of-the-art technique allowed Dr. Zavarella to remove the entire tumor and gave the Brush family a priceless day to remember.
Yeah, I walked my youngest daughter down the aisle. I danced with her, danced with the granddaughters. You know, it was a good day.
After surgery, Mr. Brush completed radiation therapy at Good Samaritan and is optimistic about the future.
Thanks to Dr. Zavarella and all the people at Good Samaritan who have been some of the best people I've ever met in my life. I can honestly thank them for helping me and getting me on the right track, and I think we're going to be in a good place going forward.
Oh, what a beautiful story. Isn't that great? Those
Yep.
success stories must just make you feel so good
Absolutely.
as a surgeon to have that actually work that well.
Yes.
I'm curious, I don't know what his recovery time was, but what typically is it?
Yeah, so this process of brain mapping really doesn't add any extra time to the actual recovery. Typically, for brain tumor removal, patients are home by day 2 or 3 after the surgery. Some patients even day 1. So this technique really doesn't add any extra time to the recovery at all.
But what it does add is an ability to ensure as best you can that they're not going to lose any functions because of the brain surgery.
Absolutely.
And I'm just curious, is everybody that's eligible for brain surgery, is everybody a candidate for this, or are there some limitations?
Yeah, so generally both adults and even some children can participate in this. It really depends on the patient's ability to cooperate with the specific questions they are being asked. There are some pathologies where the patient is so debilitated they cannot cooperate. In that case, obviously, no. But the majority of patients can participate.
And is it tumors for most everywhere in the brain, or just specific areas?
Yeah, so this is used for many different what are called lesions. They're used for tumors that originate within the brain, which are tumors like glioblastomas, meningiomas, tumors that originate from other areas and metastasize to the brain. Additionally, this can be used for vascular lesions. There are these benign vascular lesions called cavernous malformations.
Sure.
They can be located near an eloquent part of the brain, and it can be used for that. There are additional other vascular lesions that tend to bleed called arterial venous malformations. The technique can be used for those lesions as well. And then there's a form of epilepsy called lesional epilepsy. And that is where there is a focus where the epilepsy originates from to cause seizures. And when you're going to remove that, if it is in an area responsible for speech, you would want to know that beforehand and avoid that area. So it can be used for epilepsy as well.
So there's literally like a little lesion that is causing the epileptic seizure?
Yes, yes.
Wow. So the patients then can vary vastly.
Yep.
And the only thing is that if they debilitating state, so they can't
Exactly.
answer and can't be awake during the surgery. And the success rate of this sort of surgery now is, I imagine, far greater than it ever used to be.
It is. We can map down to a millimeter or two, that precise, and greater than 98% of the time, 99% of the time, patients usually do not have any sort of recognizable deficit.
Oh, that's an amazing
Yeah.
thing. You talked about the motor strip of the brain. Can you describe for me again? I mean, was that this main kind of section in here?
So yeah, it is. So it's this section here in pink in the posterior frontal lobe, and each of the area along that motor strip is responsible for a different movement. One area is responsible for hand movement, the other face movement, the other leg movement. So it's very important to know when there's a tumor there where that specific area is.
Where do you see this brain mapping going in the future?
Yeah, so that's a very good question. So right now we are close to, like I said, 98% precision. Hopefully with all the other different types of brain mapping that can be included, we can reach 100%.
How many of these surgeries do you end up doing in a year's time?
So we end up doing about 20 to 30 in a year. Sometimes, and that's for tumors. It could be more, upwards of 50 for other lesions as well.
So basically one a week or more than that?
Just about that.
And how long are they literally on the table, or?
Yeah,
I don't know if you even know call it a table anymore.
So it really depends on the type of lesion. If it's a tumor and it's a large tumor on the surface of the brain, they can be there for an hour and a half for the surgery to be completed. If it's a tumor that is more deeper within the brain, that could last upwards of 8 to 9 hours, or even more sometimes.
And they're awake during this?
They are awake for a small portion of that. Okay. So the way it works is the patient is, we have the team involving the neuroanesthesiologist, the neurologist, and even the monitoring team. Once the patient comes in, the anesthesiologist puts them to sleep, but does not put a tube down so they can breathe. So they're breathing essentially on their own. The anesthesiologist, after the brain is exposed, both the place where the lesion is and also where you're going to map. Once that's exposed, the anesthesiologist then wakes the patient up, and
that's
the
when
patient,
you ask the questions and try to determine exactly where.
What function, exactly.
Interesting, fascinating. Stick around. We're going to have more on this discussion in just a moment. Going to take a break. We'll be right back after this. Welcome back to CHS Presents Lifestyles at the Heart of Health. As we wrap up our show today, some final thoughts from our guests. From both of you, if you could each tell me where you think all of this is going and what you may be able to do to help those people who suffer from brain and spinal tumors in the future.
As I explained earlier, the technology is helping the neurosurgical patients significantly. And the technology is advanced very rapidly. What we're looking at in the future, and hopefully soon, that instead of what I explained, that I see the brain and I see the tumor, we will be able to see what we call the tract, the things we do not see with our eyes. We literally need a magnifying microscope to be able to see them. And this is the tracts that carry the functions from the surface of the brain to, let's say, to the hand or to the leg. So they go through the brain. I think what's coming soon that we'll be able to see that. So if we are removing a tumor, we'll be able to take it away from the tract instead of damaging the tract. And the other thing which I think also will be coming soon is robotic neurosurgery.
I was wondering about that.
Yeah, that we will have the robot start operating obviously we'll have to worry about our jobs, but I
Oh,
think
no, the robots need a supervisor. And what about you, Doctor?
Yeah, I'd have to agree with Dr. Shai. I think, in terms of where we're at, we're in relation to aeronautics, we're where the Wright brothers were with aviation. Very early on, nascent, and I think I don't quite think robotics will take over our field, but I think they'll assist. They'll definitely assist.
I think this is more for the young neurosurgeon to worry about.
Good point. Good point.
Well, I thank you both for the tremendous work that you do and for sharing your thoughts and your explanations and your brains with us here today, both the brains here and the brains there that are doing all the great work. So thank you.
Thank you.
Keep it up. And as always, for more information or to schedule an appointment with Catholic Health Services, simply call 855-CHS-4500 or you can visit chsli.org. Thanks so much for joining us today. I'm Jane Hansen, wishing you goodbye and good health.